The Partner 2A trial and the SAPIEN 3 trial were intermediate risk trials of TAVR. Partner 2A was a randomized trial compared against surgery, and the SAPIEN 3 trial was a single-arm study which was compared retrospectively against surgery. And what we learned from those trials from the health economic standpoint, which is what I'm presenting today, is that TAVR is really a highly favorable treatment for these intermediate risk patients. What I mean by that is that during the initial hospitalization, at least here in the United States, TAVR, even though the valve was much more expensive than the surgical valve, the total in-hospital treatment costs were similar or even a little bit lower with TAVR. And then over the next year or two, there were substantial additional savings such that by the end of 1 to 2 years, TAVR was about $10,000 to $15,000 less costly, depending on the particular study, than surgical valve replacement. In addition to that, we also know from other studies that TAVR has similar or even lower mortality in the long run for these patients, and better early quality of life. So 3 advantages of TAVR: similar or improved survival, better quality of life in the short term, lower costs. That's a win-win-win. The cost savings that we saw in this trial came from 3 things. One was reduced length of stay for the hospitalizations. Because TAVR is so much less invasive, the length of stay reduction in the Partner 2A trial was about 4.5 days shorter. And in the SAPIEN 3 trial, it was about 6.5 days shorter. And about half of that benefit was actually ICU days, which are very expensive in the United States. So that's one benefit. The second benefit occurred after the patients left the hospital, really twofold. One was reductions in hospitalizations, both cardiac and non-cardiac rehospitalizations, and probably the biggest factor was a reduction in the need for rehabilitation, which again in the United States is very common in the more elderly patients after cardiac surgery, was much less with TAVR. That led to, again, very substantial savings of up to $10,000 to $11,000 after the patient left the hospital. Hidden costs, I mean, the only costs that were not incorporated in this analysis, which you could consider hidden costs, are the costs of evaluating the patient prior to the procedure. The main difference between how we evaluate a patient prior to TAVR and surgical valve replacement is a CT scan. So perhaps there's $1,000 or so worth of hidden costs upstream that we did not capture. The other limitations are important, though. First of all, this is a United States analysis. And so it does not directly apply to other healthcare systems, at least not in the dollars and cents way. I think the general principles that the lengths of stays can be much shorter, the need for rehospitalization and rehabilitation are much less, but the precise costs that are attributed to those things may differ in other healthcare systems, as does the cost of the valve for that matter. So you would have to, this needs to be repeated, or at least reanalyzed in other healthcare systems. And the last one is that we probably can still do better. TAVR, the TAVR patients who were treated in the S3I trial here were treated largely in 2013, early 2014. We know that our techniques, our management strategies, the use of general anesthesia is less, the use of ICU time is less. All of those things have gotten more efficient in the United States, so we probably at some level are almost underestimating the cost savings. I think it should mostly be reassuring that the way that practice is moving is the correct way, because practice certainly for these intermediate risk patients is moving very much in favor of TAVR. It's been that way in Europe for several years now, and in the United States with the approval just in the last year, it is again rapidly moving in that direction. So it is reassuring. It reinforces our guidelines that say that TAVR is an acceptable, in fact, probably a favored treatment for these intermediate risk patients, and it should reassure our payers that they're getting their money's worth. I think there are 2 areas that need to be done. Number one is we need to understand how these results apply to other countries, as we already discussed, because again, the differences in prices of various supplies, hospital days, all those things are different. And then the second thing is there is still one large population that has not been studied yet, at least rigorously, which is the low-risk patients, which is the largest of the populations with aortic stenosis. And we don't know whether these results apply directly to low-risk patients. In fact, it's very unlikely they do. So I think we need to continue to extend this as we go into other populations. And then obviously the next extension is other use of transcatheter valve therapies, mitral, tricuspid. Let's understand how those work as well.